So for extra credit, since I think Dr. Leverance gave you a couple of tests already, who is this person? Can anybody identify her? Somebody suggested it was my mother. It's not my mother. Sorry? Auguste? No, she never made it to this age. No. I'll give you a hint. She was a mystery writer. Agatha Christie. Agatha Christie. So she was born in England in 1890. And for those of you who were at my talk yesterday, I promise that you'll get more material at this talk. So hang on there. She published her first novel after many, many rejections by the publishing houses. The Mysterious Affair at Styles with Hercule Poirot. And then she went on to do a series of Poirot, a series with Ms. Marple, The Murder on the Orient Express, which everybody in this room I'm sure has read. She was awarded the 1955 Mystery Writers of America Grand Master Award. She was awarded the Dame Commander of the British Empire. And in her 80s, she wrote the 1973 novel Postern of Fate. And this novel was actually written while she was in the early stages of dementia. And there have been a lot of efforts to scientifically analyze this novel and compare it with her prior novels. And I'm not going to say that I'm a literary analyst, but let me read to you one of her earlier novels. Here's an excerpt from Murder on the Orient Express. A cold wind came whistling down the platform. Both men shivered. Lieutenant Dubosc managed to cast a surreptitious glance at his watch. 5 minutes to 5, only 5 minutes more. It's short, but... And here's Postern of Fate. So, I mean, somebody would read stories aloud and you liked them very much and you remembered where the book went back on the shelf and you were always allowed to take it out and have a look at it yourself. It sort of goes on. So, with the limited reading that I've done, somebody raise their hand and tell me what you see different between these two novels. Sorry? Structure. So a little rambling. Okay. What else? Simpler language. Yes. Where are the words like surreptitiously and other things like that? She certainly, there are some similarities. There's a desire to portray a character, a desire to be creative, a desire to contribute. But a paucity of words and simpler ideas really does come out. And when this is analyzed in a more scientific manner, you know, these differences really are visible to somebody who was writing a comparison when she was writing in the prime of her ability versus at the end. So dementia is a cognitive problem, severe enough to interfere with activities of daily living. And for Agatha Christie, writing was an activity of daily living. And you can see that it interferes, even though it's not something we routinely test for. And it's not a specific disease, it's an overall term describing a wide range of symptoms. And when we think of cognition and dementia, we include memory, such as short-term, long-term, and working memory, as Dr. Leverance said, but there are things other than memory. Communication and language, ability to focus and pay attention, reasoning and judgment, visual perception, problem solving, executive function, so doing things in order. And then it's important to understand the activities of daily living because they help us understand the stage of the dementia. And we should never diagnose a dementia without diagnosing a stage. And there's different ways of staging, and I'll explain that in a moment. The basic activities of daily living are considered eating, bathing, grooming, toileting, dressing, and This includes choosing the clothes appropriate for the season and putting them on in order without being prompted, transfer and locomotion. And then the instrumental or more complex activities of daily living include transportation. And Dr. Leverance mentioned some people never learned how to drive, but they have ways of getting places, and they figured that out. You know, whether they're coaxing or paying or taxis or buses, they know that they have to keep appointments, they arrange their transportation, and they get there on time. And that's what people do until they can't. Shopping, homemaking, managing the mail. Older people take more time to manage the mail, and it may take them, instead of a few minutes when they're younger, it could take them a few hours to sort through. Medications management is something that the doctors notice or should notice early, that the patients aren't filling their medications, they're not taking them properly. Using the telephone, and being able to call 911, using devices like the remote, like the cell phone, caregiving, and pet care. You know, whatever that person usually does, a dementia can interfere with it. And a simple way of staging dementia could be mild, moderate, and severe. So in mild dementia, we're looking at a person whose basic activities of daily living are intact. They ought to look completely fine, completely groomed, no odor, not disheveled. And if you peel off the clothes, you shouldn't find things that don't belong there. So for example, I had a family who brought in a patient, and she was beautifully coiffed. The makeup and the hair and the clothing. She had been to the emergency department for chest pain 4 weeks ago. And what do they do in the emergency department when you have chest pain? They stick leads on you. So I opened up her clothes, and those leads were still on her. And the family hadn't really even known that. Maybe they suspected it, but they were explaining to me how she took wonderful care of herself. Well, she wasn't. She clearly wasn't taking care of herself from a personal point of view. Typically, a person with mild dementia has problems managing their medications and appointments. At least that's what the doctors see. Moderate dementia is impaired in at least one basic activity of daily living, like taking the electrodes off and washing yourself, as in addition to instrumental activities of daily living. And then a person with moderate dementia, you might not catch right away if you have a superficial interaction. This is the person who's at the family picnic, and she's sitting in a chair, and the grandkids come over and say hi, and she says how cute you look and what grade you're in. And if that's the only conversation you have with the patient, you may not figure it out. But severe dementia is somebody that everybody can tell. The person is not engaged. They're not clued in. They really don't know what's going on around them. And these people are impaired in most of their instrumental and their basic activities of daily living. So a person with mild dementia needs somebody to help them with stuff. They need assistance with medication management, with appointments, with finances, and with making big decisions. Dr. Leverance said that they shouldn't be driving. Some studies have shown that that's why it's important to check the stage and to understand it. Many people with mild dementia can still drive, but they have to be willing to allow a safety evaluation. And in addition to that, there has to be some insight as to their judgment. So for example, if a person is prescribed a pain medication, it says, do not take this medication before utilizing heavy equipment or something like that. That translates to don't take your Percocet and jump in a car. Will a person with mild dementia know that? So they might test fine, but then maybe they don't have the judgment not to take their Percocet. There's some things that are harder to test for. So what I'm getting at is that the driver evaluation could be very important, but it may not tell the whole story. So what is somebody with mild Alzheimer's disease like? Socially appropriate. That's the big comment. And if you ask them a question like, so what's in the news? They'll answer you, but it'll be vague. lots of bad things. The wars, the Middle East, the president, oh, I hate him. And then they're going to have trouble if you push them, naming the recent presidents. Who's the current president? Who's the president's wife? Who was the president before that? It's amazing how many of them will jump right to, like, Reagan. If you ask them a question, about 10 years ago, what happened in New York City? And see what they say. Many people will say a bombing. And when it really wasn't a bombing, we know that. Many people were killed. They'll struggle with the date and the year. They may not remember the plane that crashed into the Pentagon, but they might remember Shanksville, PA, because it was so close. It was something that was brought home to them. But ask them about Pearl Harbor if they're in their 80s, and boy, you'll get it all. You'll get the date, the combatants, you'll get the song. They'll know what ship is still leaking oil. All right, what ship is still leaking oil? Arizona. The Arizona, yes. And they're likely to remember it either because they were old enough to remember it and it was big news, or because they had older brothers or cousins in the military, or because people were talking about it when they were in school. So they grew up with it, perhaps in the same way that our kids sort of grew up with 9/11. But their long-term memory in Alzheimer's disease could be very well preserved. A person with moderate dementia is going to need daily prompting or assistance with grooming, bathing, dressing, meal prep, and no driving. By the time a person can't dress themselves properly, in general, they shouldn't be driving. And a person with mild dementia might be able to live independently with somebody coming in to set medications up for them, for example. But they're not going to be able to manage without daily assistance with moderate dementia, because they're going to need somebody to help with grooming, dressing, meal prep, etc. And then severe dementia, these people only have fragments of memory left, severe functional deficits. They need 24/7 care. And one of the things that families ask me is, so you've diagnosed mom with dementia, does she need to move into a nursing home? And it really depends. Let me just see. Let me get to that question in a moment. The other question that people say to me is, did this happen overnight? And honestly, as Dr. Leverin said, the history is really important, because I want to hear from the family if this happened overnight or if it happened gradually. And if it's a stroke or a traumatic brain injury, then certainly it can unfortunately be overnight. If it's Alzheimer's disease, it's progressive. But did you see that slide that was the pie chart that showed that most of dementia is not pure Alzheimer's disease, and most of dementia is not pure vascular disease. Most of it's mixed, which means that the progression is going to be slow and bumpy and jagged. So there may be vascular events that accelerate it. There may be traumatic, quote, traumatic events like falls or head injuries that accelerate it. But the person may progress slowly or may progress quickly. And some of that depends on genetics, some of it depends on the vascular burden, some of it depends on lifestyle. The dementia types, primarily Alzheimer's, vascular, and mixed. Parkinson's disease or Parkinsonism accounts for different dementia types. There are a few people who develop meningitis and have a post-infectious course, and then trauma. Some people ask me, so what type of dementia does Dad have? And I'll say, if I had seen them 5 or 10 years earlier, I might have been able to tell you, but sometimes at a later stage, moderate to severe, you really don't know how they started. And then we talked about genetics earlier with Auguste, and she had one of these early onset dementia chromosomes. Late onset dementia is influenced by ApoE4, and there's an important difference. The chromosomes, PS1, PS2, APP, they're destined. 100% of people with this chromosome will get this dementia, and the symptoms are visible in the patient's 30s or 40s, and then in the 50s they maybe have severe dementia. And ApoE4 influences the course but does not destine the course. The onset, the age, the intensity is influenced by comorbidities like vascular conditions like hypertension, strokes, diabetes, smoking, brain trauma, etc. So lifestyle and comorbidities. And typically, people have an onset of cognitive symptoms, and then they have trouble doing things. So shopping, bathing, continence, feeding oneself really comes very late. Most people with dementia are able to feed themselves until late in the course. Behavior problems, such as Dr. Leverance mentioned, so agitation, etc., can start early, and apathy can certainly start early. We talked a little bit about mild cognitive impairment, and you may hear this term more recently than you've heard it in the past. So mild cognitive impairment is hard to diagnose because it's missed by most primary care physicians, because the person really doesn't have much in the way of functional deficits. But it takes the person longer, and they have to work harder to maintain themselves. And these are the people who are taking extra notes. They may be a little extra anxious, a little bit extra obsessive compulsive, and you see people elbowing each other at that point. Some people can stay at that mild cognitive impairment stage for many, many years, and some people progress more quickly. And I'm going to show you a slide of something that seems to prevent progression. So who are the people who are likely to progress from MCI to dementia? So people with small hippocampal volumes, as seen by MRI, these are the people who are more likely to progress. If there's the PET scans and the amyloid scans may predict those people, and some of the CSF markers that we talked about may be more likely to predict those people. We can't do anything with those findings. We are really just predicting. The risk factors for worsening cognitive impairment are divided between those we can do something about, maybe, and those we can't. So the fixed predictors, advanced age, males may progress faster than women, lower educational level, and having the ApoE4 genotype. But the ones that are potentially modifiable, smoking, alcohol, lifestyle, exercise probably should be on top, socialization and cognitive stimulation, diet, certain drugs, vascular disease, and medical conditions. So medical conditions associated with impaired cognition include sleep apnea, and I put that on top because it's so common. Untreated sleep apnea is definitely associated with cognitive problems. It has not been shown that treating the sleep apnea with the CPAP machines reverses that, but we hope that it at least slows it down. So until more data is available, we try to identify comorbidities like sleep apnea that you can intervene with to slow the progression. Atrial fibrillation, long-standing, it's a common condition, and it is associated with cognitive impairment. Heart failure, particularly people who have repeated decompensations and visits to the hospital. Diabetes, particularly those people whose sugars are poorly controlled for many years. Strokes and hypertension, particularly hypertension that is poorly treated and uncontrolled. So pharmacological interventions really depend on the stage. So for mild cognitive impairment, there are no FDA-approved therapies. I see people coming into my office with MCI and drugs, and they're wasting their money. The studies have not shown a cognitive benefit. Mild dementia, the cholinesterase inhibitors, mainly improving the working memory. Moderate dementia, both cholinesterase inhibitors and the one NMDA antagonist, I guess that should just be one. And severe dementia, both drugs as well. And for your reference, this is in your handout, there are a lot of side effects with these medications. Diarrhea, loss of appetite, nausea, syncope, bradycardia, confusion, dizziness, sleep issues, fatigue, and headache, all associated with the cholinesterase inhibitors. Namenda or memantine is associated with syncope, confusion, dizziness, headache, diarrhea, or constipation, usually constipation, vomiting, or hypertension. And seizures as well, actually. So the benefit to these medications, there are patients who feel sharper, and their families report that they do, and they may be able to maintain their activities of daily living longer. But there are therapeutic gaps. These drugs do not delay progression. There is no new drug approved by the FDA in the past 11 years. That's really sad. Part of the problem that we think is because we did not have biomarkers to properly identify those people who would progress in their Alzheimer's disease. So one of the big reasons that we appreciate the presence of biomarkers now is for research purposes, to identify who is more likely to progress so that studies can be developed, those people could be enrolled in them, and then we'll have better drugs. So there's a need for non-pharmacological interventions. The most evidence is there for physical activity, and second and third and fourth, cognitive exercises, socialization, and the Mediterranean diet, with the caveat that all of these studies really are small and they're short term. Physical activity is felt to be good because it increases cerebral blood flow. It may lower levels of inflammatory markers. It may lower the levels of brain A-beta protein, and it may increase hippocampal volume. So these are really important benefits to physical activity. There are certainly non-cognitive reasons why people should exercise. It decreases the risk of developing degenerative diseases that increase the risk of dementia, like strokes, increases functional capacity, and it reduces sarcopenia, or muscle loss. And there was a really great study done about 10 years ago in New York City, where they selected people who had mild cognitive impairment and then tracked them over a 5-year period. This wasn't an interventional study. This was an observational study. But these were all officially diagnosed with MCI, and they looked to see who had dementia 5 years later and who didn't. And the people who were less likely to have dementia were those who had more leisure activities. Reading, playing board games, playing musical instruments seemed to have some predictive value, but dancing actually had the most predictive value. I mean, keep in mind this is New York City, so you can't include bicycling, and there wasn't much gardening or physical, playing soccer or whatever, but things that people did in New York City, dancing, and that immediately went on to the National Dance Council of America website. So dancing away the years may be the way to go. And then exercise, this is a tribute to Jack LaLanne, who even in his 90s was physically and mentally sharp. And then this is a friend of mine, Bernie, who gave me permission to show this. But he and I took a 50-mile bike ride, and then we went to a bicycle museum together. And he was 70 at the time. And then this is my son, Jacob, when he was 18, and he and I bicycled from our house to Erie. So we did a 100-mile bike ride together with our packs and our little yellow vests. So exercise starting early, but it's not too late to start even when you're older. And there actually have been meta-analyses, one done about 10 years ago and one repeated this past year, that looked at cognitive outcomes and sort of how much you need to exercise. You don't need to bicycle to Erie, Pennsylvania. But studies of about half a year showed that there was benefit to these exercise interventions. Most of the studies were aerobic, like walking. They averaged at least 3 times a week and at least 45 minutes a session. And when you're looking at these meta-analyses, you're looking at either the exercise side or the control side, and the benefit was on the exercise side in terms of completing cognitive tasks compared to control. And another systematic review was done in 2014, and the exercise interventions ranged from 3 to 7 per week. And again, even the update did show that the outcomes favored the interventions, the exercise, on both of these. There are people who studied high-intensity exercise and compared it with stretching, and found that there was an improvement in executive functioning, so following directions, doing complex things. Tai Chi, if anybody was here yesterday, there was a great Tai Chi demonstration, and that suggested a reduction in the rate of dementia compared with a group that stretched did stretching exercises for a year. And then cognition appears to be sustained. So not only do you get the intervention, do you get the benefit during the intervention, but it may be sustained 6 to 12 months after the intervention is completed. Now, cognitive exercises, there is a little bit less evidence for, and it's divided into stimulation, into training, and into rehab. So there are different types of cognitive exercises. Stimulations would be group activities, like news groups, where you're stimulating people to participate. Cognitive training is where you teach people techniques to improve cognitive function. So if you had to remember 10 things, maybe the teacher would have you think in your mind of a picture for each of those things, for example. So that's cognitive training. And then cognitive rehabilitation is trying to rehabilitate certain aspects of your life. So if you're having trouble with your checkbook, then they'll help you deal with those particular tasks. So those efforts have been studied, and cognitive exercises would be something like lumosity that somebody asked about, and hobbies like crossword puzzles, Sudoku, and reading, and compensatory techniques. So there was a meta-analysis that looked at a variety of these things. 14 of them were randomized controlled trials. 12 of them used primarily restorative techniques. 7 of them were compensatory techniques. The overall result was positive, that they were helpful. And the effect sizes tend to be sort of small, and they were maintained for about 4 to 6 months. I'll skip this. So overall, there is an effect. It may not be as lasting as long as exercise. So exercise may actually have a benefit that lasts longer than the cognitive interventions. Let me just see. Socialization. So it's been shown that people who maintain social skills, socialization, actually decline at a slower rate than people who stay in their apartment or their home, watch TV, and sort of putter around. So engaging in group activities, having regular conversation, and even going to support groups has been shown to decrease the rate of cognitive decline, reduce the rate of institutionalization. Disengagement is a risk factor for cognitive impairment and is associated with depressive symptoms. And a small quantity and low quality of social relations is associated with an increased risk of death. So they're trying to do randomized controlled trials of socialization. Is a little difficult. Most of the studies out there are observational. But there was a randomized controlled trial that put people in group activities once a week for 6 hours for 3 months. And the outcome that they measured was loneliness. And the people who were there were not moderately or severely cognitively impaired. They didn't have to be perfect, but they were not moderately or severely cognitively impaired. And the ADAS-Cog was performed at baseline and in 3 months. And the ADAS-Cog is the same test that's given to people who were studied for Aricept and galantamine and the other cognitive enhancers. And the score did improve more in the intervention group compared with the control. And there was a significant difference in the quality of life in the intervention group versus the control. And there was a area considered mental function that was an improvement in the intervention group. So socially stimulating activities in lonely elders may help to improve cognition. That's sort of the take home with that. Now, in fact, we don't usually recommend one thing. We usually recommend multiple interventions. And even if you're asking a person to participate in an exercise program, you probably are offering them some socialization and some cognitive stimulation. So it's really hard to have perfect studies of lifestyle. Many programs are done in a group setting, one-on-one instruction, even that is social engagement, and many programs that are out there in the community provide multiple means of stimulation. So there was a small study that tested a multimodal method of physical exercise, cognitive interventions, and community activities. Those who participated the longest were the most stable in terms of their cognitive scores and their dementia stage. And the study lasted for up to 4 years. So how do you, as healthcare personnel, get people into these, how do you put these findings to use? So you can encourage your patients to do physical activities like silver sneakers. Many of the fitness centers can offer older age classes or one-on-one instruction. Outside activities when the weather is permitting, and it does permit for most of the year in Cleveland, and senior dance classes, getting back to that study by Verghese in New York City. How about cognitive interventions? So Dr. McCallum was here yesterday, and he operates the Cleveland Brain Emporium, and it is housed in the Hearing and Speech Center on Euclid Avenue. And I've talked to him about opening one on the east side or the west side, but right now that's where it is. He got a little grant to open it, and it's staffed by his graduate students. And what they do is they evaluate the person's cognitive strengths and weaknesses, and then they pick computer game that targets that particular weakness. So it goes, so sometimes they do choose Lumosity, but there are other games out there. And you can actually come to the center every week or twice a week or how often you want to, and that will get you not only the participation in the computer game, but it will also get you a little bit of the social interaction in the one-on-one. And many of my patients have gone there, and they sort of gotten to know each other, actually. So they'll come back and say, hey, I saw your patient down there on Euclid Avenue, and he's not doing so well, or they'll give me little pieces of gossip about them. So there's some socialization there. We don't know, to answer the question that somebody asked, if you work on the computer game and you improve your memory or improve your hand and eye coordination, what does that translate to? Does that translate to a better job balancing your checkbook, ordering online, driving a car? It's not always clear. The more the exercise imitates your real life activity, the more that improvement on that exercise is going to improve that activity. So occupational therapy is a therapy that is covered by Medicare, and there are different things that you can send people to. There is cognitive skills, so if the person has difficulty with their ADLs, their activities of daily living, due to cognitive abilities, then you can refer them at the major medical centers here for occupational therapy to address those cognitive skills. The patients have to be willing to do it. So you can't sort of surprise them and say you're going to go to this place. They actually have to be willing to participate. The way people have to be willing to engage in physical activity for back pain or physical activity for therapy for knee pain, they have to be willing to engage in cognitive skills in occupational therapy. Occupational therapists can also check driving ability as well, and that would be a driver evaluation, and there are driver evaluations at the main campus, Euclid Hospital, Lakewood, If you have patients, at Menora Park, actually next door, has a driver evaluation. If your patients live in the Suma area, then Shaw Rehabilitation has driver evals. And Medicare does not pay for all diagnoses, but stroke is a diagnosis that they pay for. Lack of coordination is a diagnosis that they pay for. Now, speech therapy, yesterday there was a speech language pathologist who had a booth. I don't see her here today, but you can refer people for speech therapy, for cognitive issues, for problem solving. You can have family members accompany a patient to speech therapy to engage with learning ways to communicate and with people who have cognitive problems. And then you can recommend at-home activities, games, puzzles, electronic resources, reading, school books, etc. Socialization, there are senior centers all over the Cleveland area. Local churches and temples often have adult daycare programs, things that are appropriate for different stages of dementia. There are support groups for the families, and there are volunteer opportunities. One of the important things to keep in mind is that the person with dementia can only live in the community as long as there's a caregiver for that person. And the caregivers are at risk for dementia and depression. There is some evidence that suggests that support groups reduce the risk of institutionalization of the patients and help protect the caregivers as well. Dietary modifications, I thought I would just say a few words about. People are always asking me about vitamins and D and ginkgo and et cetera. Probably vitamin E and the Mediterranean diet have the most evidence. And there was a study published this past year on veterans who were randomized to vitamin E, memantine, both or neither. And they did find that vitamin E was better than placebo. But not all studies are favorable to vitamin E. There was one study, a very small one, published in 2009, where there was no benefit. There is an increased risk of bleeding with warfarin and when vitamin E is used in atrial fibrillation. There's no benefit to vitamin E in cancer, cardiovascular disease, or mortality. And there was a study published that suggested that vitamin E supplements increased mortality slightly. That doesn't mean that taking in vitamin E in the form of vegetables is a problem, but when you add to it supplements, there could be a problem. And it was dose related, and this is the increased risk of mortality. This is actually a different study in 2005, and these are very high doses of vitamin E in this area, 2,000 units or 1,000 units twice a day. Now, the Mediterranean diet may delay the onset of dementia, and people mean different things when they say the Mediterranean diet, but primarily plant-based foods, fruits, vegetables, whole grains, legumes, and nuts, replacing butter by healthy fats, reducing sodium, eliminating or limiting red meat, eating fish and poultry at least twice a week, and red wine, although it has to be very clear that it's no more than once a day. And this is the Mediterranean diet, where fruits, vegetables, grains, herbs, spices, beans, these are the majority, and then smaller amounts of fish and seafood, poultry, eggs, cheese, and yogurt, and meats and sweets. So these are the different studies out there. And there was a recent study published called the Predimed and Cognition, and they randomized people to a Mediterranean diet with extra virgin olive oil or a Mediterranean diet with nuts. There was no real control group here. Or there was, but it was sort of a low-fat diet. And the cognition was better with the extra virgin olive oil or nuts compared with the low-fat. The differences were tiny. The low-fat diet was actually probably a pretty healthy diet as well. Non-pharmacological interventions, so we just talked about exercise, cognitive, social, and diet. Theoretically easy to implement, readily available in the community, at least in the Cleveland area. No side effects, high risk, low risk, high reward, and can be used at any stage of cognitive impairment. And then the barriers, people can deny that they need to do it. They could be unaware that, or have lack of insight into their deficits. They might have difficulty following tasks. Apathy, as Dr. Leverin said, people are sort of stuck at home and they don't have the incentive to do things. Cost, nothing is free. And then limited perceived value of the task. So a healthy lifestyle does delay progression of cognitive problems, social, mental engagement, physical activity, maybe the Mediterranean diet. So with that, I will close and ask if there's any questions. Question.
A couple of the things that you went through said it would last maybe 4 to 6 months. Do people keep doing those things, such as exercise and a couple other things that were in the thing? Do they keep on going beyond 4 to 6 months, or is that it?
So what happens with these studies is that there's an intense intervention for a period of time, like 3 months or 6 months, where people are brought together and they exercise, and then at the end of 6 months you see where they are, and then they may or may not follow the exercise regimen later. So most of these studies they did bring people back after a year and 18 months and 2 years, but they weren't measuring how much they participated in the projects. Now there are some other studies which were more expensive where they put what's called an actigraph on them, so they measured how much the people really moved around. But the answer is we don't really know how much they really participated in the lifestyle interventions. We assume that they participated less as a group. So if you take that assumption that there are some people who continue to participate and that most people sort of participated less, then the exercise seems to last longer than the cognitive interventions. I hope that's helpful.
So if they keep exercising, they keep having improvement.
Well, we're assuming that everybody exercises less than they did during the study, and we're assuming that everybody does fewer sessions on Lumosity and the other games when they're done with the study. So taking that as a group, there is more benefit or a longer benefit from the physical activity than the cognitive intervention. Yes?
You just went through this thing where it said the 4th grade reading, writing, math books. Are you familiar with this? That that's supposed to make, to help. Are you familiar with that? Or
The question is something about 4th grade reading and math? I don't know.
Yeah.
I guess I don't know what you're asking.
Are you familiar? Is that something that you would recommend? What's the question?
What's the question?
Is that, that doing 4th grade workbooks for people with mild to moderate, dementia, that helps them with their cognitive.
So the question is, and I'll broaden the question because I don't know the answer to 4th grade versus 3rd grade or 5th grade. But there have definitely been studies. The SAIDO, SAIDO, is an example where they take people who have dementia, and it could be mild, moderate, probably mild to moderate dementia, and they give them cognitive stimulating exercises, and they involve math, reading, categories, things that you could find when you're in elementary school, but they're made more relevant to the older population. And they work with them 30 to 45 minutes 3 times a week, and they find a stabilization of cognition, less decline, and fewer behavior problems. The caveat is that these studies, like the SAIDO, are actually performed in the nursing home or in a memory unit. And in the memory unit, you're getting more intervention than just 30 to 45 minutes 3 times a week. You're surrounded, hopefully, by staff who are supportive in activities of daily living, encouraging people to walk and to do things and having stimulating activities during the day like news group and participating in things, using Wii when, these Wii things when it's available. So there's added value to exercises that are sort of like fourth grade, but I've never heard somebody call it a fourth grade workbook. And the ones that I've personally seen are made more relevant to the older adult. Yes?
My question's a little bit two-part, but it's connected. Dr. Leverenz referenced the idea of executive functioning being an indicator that he looks at. And how does that play into people who have executive functioning challenges to begin with? And do you see any correlation between, because we're coming on a generation of people who have acknowledged executive functioning, ADHD, and those sorts of thinking problems. And does that have any connection to development of dementia or?
I'm not sure I understand the question. Is there a shorter way you can ask that question?
Well, the idea of he's looking at someone and saying if they have executive functioning problems, that's one of the main indicators of the diagnosis. What if someone always had that?
So I think the question is, when we're taking a history of what of their function, then if they already have an executive problem, like if they were diagnosed with ADD or ADHD, is that going to count against them somehow when we're evaluating them for dementia?
Well,
Is that your question?
but how does it play into it?
How does it play into it?
And is there any
So in
connection to
general,
anything that's
I'll try to answer it. So in general, dementia is a decline from a prior level of function. So for example, if we're looking at somebody who could never balance their checkbook when they were 20 or 30 or 40, and they come to us and they're 70 and they can't balance their checkbook, we don't hold that against them, although we don't consider that they have declined in that activity of daily living. So it's very important to know what the person's prior accomplishments were, both in terms of managing their home life, their education, and their job. So for example, we have some patients who completed high school, but they then went on to become a CEO. We have a very high expectation of that person's abilities when they're 80 because of what they accomplished. On the other hand, and if they have a decline, if they now can't balance their checkbook, we really look at that as a problem. Whereas we also have people who were born in the South, they dropped out of school at the age of 9 in order to help on the farm, and then they came to Ohio and they had a domestic job. If they were never really able to manage their finances and to read at a high level, we don't hold that against them either. We try to look at the entire socio-economic picture and the accomplishments that the patient had. So I hope that that answers it.